Okay, good evening, everyone. Warm greeting to everyone. My name is Dr. Malini, and welcome to this C20 webinar about suicide. We're going to look at trends in suicide. We're going to also look at prevention methods and have lots of interaction. It'll be an interactive kind of webinar where questions will be asked and our panel will respond to the questions. And then you also will be invited. After we've said all our initial questions and responded to them, all of you in the audience will also be invited to share questions. We'll start the evening with a very brief video about integrated and holistic health for C20. So Abhijit, would you share that video?
This year, the C20 Integrated Holistic Health Working Group will comprise 7 subgroups with areas of focus that include mental health, nutrition, women's and children's health, elderly care, holistic health including traditional medicine like Ayurveda, as well as yoga and meditation, the reduction of non-communicable diseases, and One Health, a concept that highlights the interdependence of human, animal, and environmental health as one species, one world. Delving into these themes, we aim to widen the discussions on different facets of Sustainable Development Goal 3, good health and well-being, with policy building meetings and series of public webinars and awareness campaigns that will take place throughout 2023. These discussions will bring together health professionals, educators, and leaders from across the public health landscape to formulate policies that support global health and well-being. Inspired by the humanitarian activities of Amma, Shri Mata Amritanandamayi Devi, the present chair of C20, we hope that this upcoming series of events will raise the general awareness in society and spark interest in people to contribute to the conversation surrounding global health. As we embark on this journey to understand the health of the world around us, C20 will offer all members of civil society an opportunity to recognize how our individual experiences and efforts can lead to policy change. Let's work together to create a healthier, more equitable world. Good health is a fundamental human right, and it's up to all of us to make it a reality for everyone.
Thanks a lot, Abhijit. So before I give an introduction about the webinar, I'd like to introduce a really wonderful panel of speakers that we have here. I'd like to start with Swami Dayamamritananda Puri. He is a senior monastic disciple of the chair of C20, Mata Amritanandamayi Devi. We refer to her affectionately as Amma. Swami met Amma more than 37 years ago, and he is now the executive director of MA Centers, which is a nonprofit organization started in California in San Ramon. And for the past 25 years, he's traveled extensively across cities in the United States, in Canada and South America, giving spiritual talks, counseling Amma satsang members, and answering questions for people. He leads numerous humanitarian initiatives for the MA centers in all of these countries I mentioned, and tours tirelessly to inspire people in their efforts to better serve their communities. And he helps them to keep alive that flame of selfless service that Amma teaches and inspires in all of us. Swami holds an undergraduate degree in physics and a master's degree in film technology. Swamiji, very warm welcome to you. So happy you're joining us tonight.
Well, thank you. And I'm really honored to have the presence of all the other speakers and to be with them. Thank you again, and thank you to you.
Thank you, Swami. Our next panel member is Dr. Cheryl King. Dr. Cheryl is a professor in the Department of Psychiatry at Michigan State University in the United States. She's also the director of the Youth Depression and Suicide Prevention Program at the university. She's a clinical psychologist, an educator, a research mentor, and has served as Director of Psychology Training and Chief Psychologist in the Department of Psychiatry at her university. And twice, Dr. King has received the Teacher of the Year Award in Child and Adolescent Psychiatry. Dr. King's research focuses on the development of evidence-based practices for suicide risk screening, assessment, and intervention. She's provided leadership from multiple federally funded research projects, including a few that we're hoping she will speak about this evening. Very, very happy that you joined us, and a very warm welcome to you, Dr. Cheryl King.
Thank you so much. It's really an honor to be here, and I look forward to hearing from all of our speakers.
Okay. Dr. Sumitra Patare, a psychiatrist here in India who is the director of the Center for Mental Health Law and Policy. This is a non-profit organization in Pune, Maharashtra, at the Indian Law Society. Dr. Sumitra was appointed by the government of India to help draft India's first national mental health policy, which was released in 2014. A few years later, he provided technical assistance to India's Ministry of Health and Family Welfare and drafting a new Mental Health Care Act, the Act of 2017. This is a very comprehensive and wonderful document which takes a rights-based approach to mental health care. Dr. Sumitra also served as a WHO World Health Organization consultant in many low and middle income countries, helping them in drafting and implementing mental health legislation and policy. And currently, he is the co-director of 2 research projects for suicide prevention, and we also hope to have him tell us about these projects. Dr. Sumitra, we're again very happy to also welcome you, and thank you so much for being with us tonight.
Thank you, Malini. Pleased to be here and look forward to an interesting conversation with all our participants, including the panel members. Thank you once again.
Okay, thank you, sir. Gabriella Wright. Gabriella grew up in both London and France. Gabriella is a highly accomplished and respected actor, a mental health activist, and the co-founder of the Never Alone Foundation. She co-founded this with Deepak Chopra. In terms of her acting career, Gabriella has played many roles, including that of a queen in an acclaimed series that drew nearly 1 million viewers. But she has starred in numerous other series and films and television programs and movies, far too many to list here. Now, in terms of her mental health advocacy, the Never Alone Foundation that she co-founded promotes mental health awareness, scientific research, and policy recommendations. She is passionate about promoting positive mental well-being and has worked with global organizations and governments to help uplift youth in many countries, and including here in India. She contributes to many international campaigns as well, such as on gender-based violence and suicide prevention. Very warm welcome to you, Gabriella. Thank you for joining us.
Oh, hello. Thank you, Malini. It's so lovely to be here. And it's so lovely. I look forward to learning from each and every one of you, because there's one thing about being a mental health activist and advocate is that you learn from everyone. And so this is going to be very exciting. Thank you for having me. Thank you.
It's a really wonderful attitude, and we can all learn from that. Thank you. Mr. Thomas Marchand. He grew up in Europe, in the country of Belgium. And pardon me, I have another little bio for him, and I want to make sure I share the correct one for him. He was born and raised in Belgium, and he's now a resident in the United States. Thomas is a product manager at a software company, and his early childhood was filled with the adventure of the great outdoors with his sister and cousins. And since childhood, his family would visit the programs of some of the great Eastern philosophy teachers that would visit Belgium. But Thomas also struggled with bullying in his teen years, which led to severe depression and severe suicidal ideation for many, many years. He is going to tell you his story and how he raised himself up from this situation and has been able to shift his life into one of deep contentment and happiness. One of the biggest ways that he has found his way to a better mental health is through community and selfless service. So Thomas will share these things with us this evening, and he will comment on other questions as well. Thomas, very, very warm welcome to you. Thank you for joining us.
Thank you for having me. I hope I can contribute something useful. And otherwise, if I say anything wrong, please correct me. Thank you.
Okay. And we have another person I'd like to introduce. He is not officially a panelist, but he will be summarizing everything that is shared this evening in this program, and that is Dr. Sarthak Das. Dr. Sarthak has over 25 years of experience as a public health scientist and a development practitioner and a global health policy advisor. He is a research scientist in the Department of Health Policy and Management and a senior advisor for research, translation, and global health policy at the Harvard Global Health Institute. Dr. Sarthak has worked tirelessly in many countries to support health and to minimize disease among rural and remote populations. And for example, in West Africa, he helped with the Ebola virus outbreak response efforts in both Sierra Leone and in Liberia. And prior to that, he spent 7 years in the highlands of Papua New Guinea, leading a collaborative effort with the government to decentralize HIV treatment among some of the world's most remote communities. Dr. Sarthak and his equally accomplished, wonderful wife, Andy Cardamone, are both senior members of the International Advisors Committee of the Civil 20 or C20 India this year. Dr. Sarthak, thank you so much for taking the time to be with us tonight.
Thank you for having me. I really look forward to listening. Thank you.
So I would like to now give just a brief introduction to this webinar in terms of why we're having it, and then we'll jump right into questions with the panel. Let me say to start that around the world, at least 1 billion people globally have mental disorders. But even that estimate is considered to be somewhat low, given that depression and anxiety worldwide have increased tremendously during and since the COVID-19 pandemic. If we look at a global level, 34% of our adolescents from the ages of 10 to 19 are at risk even now of getting some kind of depressive disorder. And up to 30% will likely have an anxiety disorder by the time they're age 18. So mental disorders and other factors can increase the risk of suicide. And this is the 4th leading cause of death among youth aged 15 to 29. In 2019 alone, according to the most recent estimates, more than 832,000 self-inflicted deaths were reported around the world. Low and middle income countries accounted for 77% of these, but high income countries also have high rates of suicide. So this is a very, very important topic. For many people, it's an uncomfortable topic, not so easy to talk about. But as I hope we all know, if we avoid talking about important topics, for sure things will not change. And if they do, they might change for the worse. So when we face problems and talk about them openly, we can work together collaboratively towards finding solutions, finding ways to prevent and reduce suicide or self-inflicted deaths. So we're actually very happy that all of you have joined us in this discussion this evening. As I mentioned earlier, the format is interactive. Questions will be asked and the panel will answer the questions. And after the initial several questions have been asked, we will invite those of you who are in the audience to also add your questions. And actually, you can add your questions in the chat at any time. So with that introduction, we'll start with a very simple first question for the panel. And this is for anyone, all of you. In your experience and in your opinions, how does suicide or self-inflicted death affect the friends of the person or the family or the colleagues? I open it to all of you.
Good morning. I'd love to start this actual answer just because I've experienced it personally. I lost my little sister to a suicide. It will be 5 years ago, and in June. And first of all, it's not something one can imagine. You know, we never imagine something that is a global conversation, and it happens so close to home. And so first of all, there's the ultimate shock of seeing something that is a global phenomenon, hearing about it in the press, hearing about it in journals, on the news, here and there, X and X celebrity just, you know, died by suicide. And then all of a sudden it's in your family. And at that point, it's almost like, I would say an out-of-body experience, because you're in shock. And when I say you're in shock, you're experiencing extreme shock. And it's almost as close to a collective, quote unquote, sinking ship. And when I say sinking ship, it's like a collective suicide. The mother, obviously, my mother was extremely distressed. She didn't want to live. My father didn't want to live because my mother didn't want to live. My other sister was just like, well, if everyone's not willing to live, then I'm not going to be willing to live. And so it was a collective disarray that was completely overwhelmed, because there was the not only the guilt, we can get into the details after, but just to really be precise with your question, it's a tsunami, and it takes a lot of time and a lot of resilience and a lot of love to get the family and the friends out of that pit hole once you've lost a family member to suicide. And that's what we often don't talk about, actually, Dr. Malini. You know, we talk about the one suicide of the person, you know, we talk about that absence, but then there's a whole emotional, a whole gap with life after that, with your family members and with the friends. And there's an ecosystem that is very much lacking, that supports the aftermath of family members. And it's up to you. You're alone in that, to support the family. So I just wanted to set the stage, because that was something that obviously is very personal to me. And that is the why of why I'm here today as well, and on this mission.
Thank you so much for sharing that very powerful story. And it looks like we have others who would like to contribute to that. Dr. Sumitra and Dr. Cheryl Swamiji, any of you really?
Yeah. Hi, thanks. Thanks. I'll go first and be quick about it. I just wanted to pick up from where Gabriela left, really, which is that I think Gabriela very poignantly kind of narrates her own story and her family's story. But what I wanted to point out is that if there are about 1 million suicides every year across the world, we know from research that about 15 to 20 people are affected by each suicide. This not only includes family and loved ones, but also colleagues, includes friends, and other people around them. So if you're looking at 1 million suicides, you're looking at 15 to 20 million people who are affected by that one suicide. The other thing that we don't account for in the 1 million suicides is the fact that more than about 15 to 20 million people attempt suicide every year, which is a rate which is 10 to 20 times the suicide rate. And then you multiply that 20 million by another 20 million, which is 20 people affected by it, then huge numbers of people who are affected by mental health, by suicide and attempted suicide. You said earlier, and I think it's an important point, more than 75% of people who die by suicide or even attempt suicide actually live in low and middle income countries. Unfortunately, in most of these countries, there's no post-vention support, as we call it technically. That is support to the survivors of the suicide, support being provided to families and caregivers and loved ones. There's absolutely nothing. Like even in India, for example, we don't really have any formal post-vention support that is available. So effectively, people are just left to fend for themselves, work their way through grief, which leads to long periods of grief and also results in all kinds of health problems for them. We know from research that people who survive a suicide, near ones, close ones, also end up having a lot of mental health problems post the suicide. Now, that's something that we don't address at all. And it's compounded by what Gabriella said, which is about the guilt that goes with it, as if, people feel that they made a mistake. Maybe it was their fault. And if you're not going to provide people with the kind of psychological support that they need after an episode like this, then really we are failing large numbers of people across the world who just have to plow their way through it and hope to come out on the other end of the tunnel. And that might take months, it might take years, and in some cases, people never manage it at all. So I think it's a very important point that we need to address. The people who survived, the people who did not die, they suffer as much as anybody else. Thank you.
Thank you so much, Dr. Soumitra. And I just invite all panel members to just jump in as you need to. But definitely, you're certainly validating the very real experience that Gabriella has shared with us. So others, please share your experience as well.
Working closely together with family members and loved ones who've lost someone to suicide, I think a few different experiences seem to be nearly universal. And one is, has been talked about, this maybe guilt, shame. Anything I could have done differently that day, the week before, the year before? But the others, one of them is a search for why. And I think what we see is that this can be a lifelong struggle to try to answer why. Why did this happen? And why maybe didn't we pick up on it? And we never can really answer it because there's such a multitude of factors that are like transactionally impacting each other over time before someone dies by suicide and makes that choice. It's complicated. And so there's never like an answer people can grab onto to why. And I think the other experience that seems to be with almost everyone with this tragedy is that sometimes at the very time the most support might be needed, the people in the community might even pull away a bit because they don't know what to say. They don't know how to talk to the person. They want to be helpful, but not knowing, am I going to make it worse? Am I going to say the wrong thing? Is that sometimes they actually take a few steps back at the very time when the person may be needing the most support.
Just waiting if anyone else wants to respond. I just have to go. Please go ahead. Go ahead, Gabrielle.
Thank you, Dr. Malini. First of all, thank you, both of you, Dr. Soumitra and Dr. Cheryl. I think these are very, very poignant pieces of information. But just to respond to Dr. Cheryl, the journey of the why is probably one of the most important journeys when you are, quote unquote, the survivor of the person who has disappeared, who has taken their life. And what that why journey does is that it gets you to that there is no why. And that is a wonderful, wonderful place to be in. Now, I'm saying this here because there is another side to the journey. There is another side to the journey for the survivors. We're talking about lack of infrastructure here. We're talking about the taboo of not being able to address use certain words to help, the family, the survivors, the friends. I was literally on 2 conversations yesterday with incredible, brilliant young women who had lost their friends, not even their sisters, their friends. And one of them, I'm sharing this story, she was like, wow, I realized there is no why. And it's been a year into losing this friend of mine, and there is no why, and I've accepted that. And it's freed me to participate more in these conversations. So this is when, the community gets together and can embrace the journey of others. So I just wanted to also give a little, storytelling to what you were saying, Dr. Cheryl, because it's so important what you said.
I'll just comment on that because it's like the transition from what Dr. Cheryl said about it. There's something very haunting about not being able to ever really understand. But when you move it to there is no why, you've moved into a place of acceptance. And then at least some peace of mind can come to the survivor. It doesn't mean that we have complete understanding, but at least we don't have to have that mental torment. So thank you so much. Swamiji, did you want to share something also?
Yes, yeah, I mean, all of the panelists have given so much value, suggestions, and I would like to add just one more thing. Other than the guilt, shame, and which I have perceived amongst especially the Indian families, is that they are in denial of suicide, and they don't. It's a shame for not only for the person who did, but also for their family to admit the fact that the person committed suicide. So they publicly do not want to address this, in one sense, and admit the fact that the person committed suicide. So what happens is there's a repression of their emotions, and which, after some time it has to come out. And many cases I've seen that this guilt and shame and all the repressions just burst out. And also one of the other things also, as Gabriela was saying, that there is also a spiritual searching to understand the why. And many times, since we do not understand the question as to why the person did this, it's a spiritual journey into ourselves.
Absolutely.
Malini, I just wanted to add one more point, and since this is the G20 and the C20, I think it's, we really need to call upon our leaders to fund and establish these kind of support services, the post-vention services that are urgently and desperately needed, especially in low and middle income countries. And it's not rocket science. Post-vention services, very well researched. We know what needs to be done. We know how it is to be done. We know who can do it. We have the trainings in place. What we do not have currently are both the financial and the human resources to put it into place. I mean, in many ways, I think this is one of the lowest hanging fruits in the whole suicide prevention work that we could be doing. This is about taking care of those who survived. While we need to do things to prevent people from dying, let's start looking after the people who've survived that, and this is something that we should be really calling upon our G20 leaders to really actively look at funding these. And they're not expensive. These are actually relatively cheap services to put into place for us to be able to benefit large numbers of people.
Thank you, Dr. Sumitra. Absolutely correct. And I'll just add that Sumitra ji has been helping us with writing policy statements related to the mental health part of C20 under the health vertical. And particularly, he's contributed so much to this area of suicide. Thank you.
Yeah, I would like to add one more thing to that, because it's just merely not psychological counseling that the suicide, either the victims or who could not successfully attempt to take away their lives, but also the relatives of the the people who have committed suicide. They would need also some spiritual counseling as well. So it needs to have also a spiritual aspect to that. I'm just adding that because I've seen that merely the psychological counseling is not sufficient for many of them.
Thank you, Swami, and I think very wise words to share.
I would like, if possible, to add just a small note from the other side of of this conversation, as someone who sat at a table attempting to write some kind of letter to explain why I was planning to do what I was planning to do, which I'm here. So, I got through it, and I'm in a much better place now. But for anyone who is a family member of someone who did commit suicide, I just want to say, for me, from the place where I was sitting, there wasn't anything that my family could have done. And my whole focus had been trying to find some way to kind of absolve my family, which in the end, I didn't see a way to write one letter that would somehow absolve my family of any pain and guilt. But it is just an incredibly difficult, I think, situation for both sides. And I think, the why is a very difficult thing. And but I don't think people should be ashamed, and I don't think people should feel guilty for something like that happened. Because at the end of the day, that doesn't help anyone forward. And in fact, I think it just helps making families who suffer with this to feel isolated, like they're the only ones suffering with this. And it makes people who suffer with suicidal ideation feel that they're alone and that there's no one else around. That's what I wanted to add to this.
Thanks a lot, Thomas. It's really wonderful to get different perspectives. Just related to this question, because one thing that Dr. Cheryl was saying is that there are so many different factors related to why people might take the act of harming themselves, killing themselves. But let me ask now the panel, from your experience, in spite of the fact that we know there are a multitude of reasons that people do this, could you tell us, just from your experience, what have you observed? Are there some most common factors that drive one to the act of a self-inflicted death? So, for example, perceived failure or relationship difficulties, or feeling ostracized or socially alienated from others. Just want to hear opinions from all of you, if you see any particular trends in your own area. And one thing we also heard when Swamiji spoke is there are also cultural differences. And of course, this is true worldwide. So if you would just respond to that question. What are some of the more common things that maybe you've noticed in your experience, those of you who work with people who might have emotional struggles in particular?
I'll start just because I'm sharing what we've discovered. So what we've discovered is that it's severe isolation and loneliness has been one of the main triggers as a basis, as a foundation. So you might have other ailments, other, anxiety, things, more mental illness that can be triggered, but triggered by the fact of loneliness. And loneliness, as you know, is also an epidemic as well. And we don't talk about that. Family structures have changed shape over the last 50 years. Certain cultures, as you were saying, Dr. Malini, have different approaches to family structures, and families are the knot of existence. They're our anchor, per se, and there's a lot of division now in families. Divorce rates are high. Kids are sent to school outside of the villages or the different cities, and everything is just destructured now, and there's a different relationship to togetherness. Our initiative is called Never Alone because we understand, and we've understood that the root cause is loneliness. And maybe if that one moment in that choice, because remember, there's the preparation to the choice, that I'm going to take my life. There might be the inner dialogue of that, or the physical, okay, these are the actions that I'm going to undertake now to plan this. But there's always a moment in time. And that moment in time, if you're not alone, maybe that action will not happen. So there's a lot of, this is like I say, this is another gray question. And I'm sure everyone on the panel will, because there's not one answer here. It's completely, I always like to frame a mental health that, yes, it's a universal problem, but it's an individual response. And everyone has their path culturally, religiously, and from the story of their lives. Everyone has an individual relationship to their life and to the individual relationship to their goals. So that is something that we're looking at. But like I said, there are many, many factors, and it really depends on your social, economic, family, structure, cultural, and religious background. And I'm sure, like Swamiji said earlier, unless there's, quote unquote, a path to freedom, which is almost a spiritual, quote unquote, emotional education that is beyond the you, that takes the you out of the question and others, then you start to become at one, and you start to experience a connection with everything and everyone. But that is a journey, like we said earlier.
Just to build, I think, on what Gabrielle is saying, because I do think we often see at the point of a suicide attempt or a suicide, this isolation you're talking about, and inner turmoil, agitation inside, like unbearable emotional pain and isolation or conflict with others. But some of what we look at, what we see, depends on how close we are to when they actually engage in the suicidal behavior, how far downstream or upstream. Because I think there are, and Gabriella mentioned all the factors, there's a lot of things that can get that person to that point where they have this inner pain and turmoil, and they end up isolated or in conflict with others. And, we do see, moving a little bit upstream, a lot of depression and hopelessness. Here we see, in my nation, the United States, we see a fair amount of alcohol and drug misuse in young people who are dying by suicide, not in all of them, but in some different patterns. And a pattern maybe of aggressive and impulsive behavior, conduct disorder problems in young people. And when you put together depression, hopelessness, let's say alcohol use, it's a central nervous system depressant. It's disinhibiting, and you're really upset. That creates problems. But we can also go even further upstream. And we know that lives of chronic stress, lives with many traumas, child maltreatment, physical and sexual abuse, they're also sometimes, again, not in all youth who die by suicide, but chronic stress, child maltreatment, and traumas, they can really set the stage. And many of our youth at risk, not all, also have this in their background. So it's, it can be building over time for some, and for others, it's more recent problems in maybe the last weeks, months, and year.
Thanks so
Yeah,
much.
one of the recent things that I've been noticing is that there has been effect for many people as to when they take certain medicines, especially when they are depressed, that leads them to suicide. And especially, I wouldn't say just depression alone. There are other medicines. Sometimes there are cancer patients who get the chemotherapy. And that also, I have seen in some people that also leads them to taking their own lives as well. So I feel that some of them do not understand why they are doing this. So it's some of them is drug-related causes also.
I just wanted us to step back a little bit, and I know all of you have spoken about all of these issues, which I think are equally important. But I wanted us to step back from, we think of suicides and when they happen as something that an individual does or happens to an individual. And I want us to step back from this individual perspective to a more structural and societal perspective. And the reason for doing that, is two reasons. One is, if you look at the research data for suicides from places like India and even now recently from the US, when you do psychological autopsy studies on people who have died by suicide, only about 40 to 50% of them would have had a diagnosable mental health problem. Okay. The others do not. So like as somebody said in the comments, I couldn't pick up when my brother was suicidal. I wouldn't have known that. And that is true because about half of the people do not have those factors. But I think what we are missing in many ways is structural factors. And what I mean by structural factors are, the structural factors act a little bit like a tsunami that washes over even the strongest of people. If you lived in a city with a huge amount of pollution, you will get a lot of people who have chest problems. It has nothing to do with individual vulnerability, but the fact that you live in a very polluted city. And if I can use the same analogy to suicides, if you have financial or economic crisis, like Greece, for example, in 2008, we had suicide rates go up by 10, 15, 20, 30% for the subsequent 3 or 4 years after the financial crisis in Greece. Post-COVID, for example, in India, suicide rates have been up for the last 2 years by 10% and another 7%. So that's like 17, 18% up since COVID. Then there are other structural issues. So things like unemployment, financial crisis, social upheaval, all of these play a big role. And I really do think that we need to be calling upon our leaders to address, because these structural factors are not something that you and I as individual citizens can do much about. This is something that societies and leaders of societies need to start addressing and doing something about. We don't, and there is evidence. Okay, I'll give you evidence. Brazil, for example, in Brazil, they implemented a cash transfer program, and over 15 years, the people who had received the cash transfer, it's a small amount of cash transfer. People get $17 a month, the people who are financially not well off. And what you find with that is suicide rates in that population over 15 years reduced by 61%. Okay, that's a huge reduction, 61%. In similar studies in Indonesia, Kenya show 18-20% reduction in suicide rates. Now, these are structural solutions to structural problems. In India, for example, a change in the education system slightly in one state in Tamil Nadu reduced exam-related suicides by 50% over a period of 10 years. So these are, what I'm trying to say is that our leaders need to be making those changes to policy to actually bring about improvements. It's not all individual. I mean, the only point I wanted to make is there's a lot of stuff that is not individual and is structural, which is not being addressed at the moment.
To add to that, one of maybe the biggest societal cultural changes that we're trying to understand how it seems to be paralleling with an increase in young people's suicide is the growth of technology, phone use, social media. It's very hard to get a handle on it. We all count on it. The world's not going to go back. But what we have seen is a pattern of increasing isolation among young people. They are connecting with others via text messages and social media. But actually, I don't know the worldwide data. I know in the United States, young people are actually not getting together in person with each other as much anymore or with others. They're connecting in their rooms via text messaging. And we have very parallel patterns from when social media came on the scene, when cell phones became available to the US, that parallel our increasing rate. Now, that's not cause and effect. We're trying to get a handle on it, but it does seem to be building evidence that we have to find a way with all of our new technologies. This is definitely a societal level, not an individual level, although individual vulnerabilities are important. It's like many of these structural and societal things, they don't seem to be putting everyone at risk for suicide. But when you combine this with vulnerabilities in the community or individual family level, you can have increasing risk.
Very good points, really very good points, everyone. And actually, it reminds me of a young man who came to me a few months back and was telling me about his multiple suicide attempts. And he said very spontaneously, social media was supposed to bring everyone together and everyone's always on social media. He said, but it just made us more isolated and alone. And I think that's really the experience of many people. I really thank everyone for these wonderful responses. I also want to just share quickly a couple of stories that people shared in the chat. I lost my little brother this January, but as a student of counseling, I couldn't find any extreme symptoms from him. And this is what we spoke about just now. Therefore, the reason of his suicide is still unclear. Obviously, it's very new to me and really hard to bear it up as his closest family. Absolutely, it's extremely difficult. It can be confusing. As Dr. Sumitra said, we have lots of research that shows a relationship between something like depression or depression and anxiety, or depression and sleep disturbance, and a higher risk of suicide. We have just as many studies that have no mental disorders connected to someone making a suicide attempt or completing a suicide. So it's not so clear cut. And I think that's what many of you are saying.
Malini, I just wanted to add a couple of things because I think it's really important to highlight some of these issues. A third of women, young women who die of suicide, have a history of being survivors of interpersonal violence or what is called domestic violence. Okay, now that's a huge structural factor that we are still not addressing very well. Almost a quarter to a third of men, young men who die of suicide, have a history of excessive alcohol consumption. Again, another structural factor that we do not address. And in many ways, these are all interlinked because the alcohol consumption is also interlinked with the domestic violence or the interpersonal violence, and the two of them are interlinked to suicide. So it's a triad of things that we really need to address at a societal level, not at the individual level, which is interpersonal violence, especially gender-based violence, alcohol consumption, and suicides. And if you're able to do, it just shows you the interrelatedness of all of these things and why addressing one issue actually needs you to address 2 or 3 other big structural issues at the same time.
Yeah, thank you so much. And I just want to reassure all of you who are listening that we will definitely be having time for you to also share your perspectives, and not only in the chat, but some of you may want to share after a little bit longer through this webinar right now. Thomas, did you want to add to this part of the discussion?
Yeah, everything I'm hearing about society and societal problems, it's very interesting, and I think it's very important. It's harder for me to speak to that because I'm not a professional like most of you here. But I do also think that there is some and this might change from society to society, I'm not sure, but there is some cultural influences also. I remember one of the things that, especially in Belgium, and I think across the West, there's this concept of your teenage years or your childhood time or your university time or whatever it is, you know, like these are the best years of your life. And this is kind of a message you're getting constantly from parents, from uncles, from television. Hey, you should be happy. This is where it's at. You know, it's only going to get more difficult from here. And as someone who's struggling, who's being bullied, that creates, and I think this goes a bit back also to what Dr. Cheryl was saying, is this sense of hopelessness. Like we create these concepts in society. For me, when I used to hear those things, I thought, wow, if this is supposed to be the peak, what am I really continuing for? Like, what am I really living for? If it's only going to get worse, then like, what's the point? And I think it's important for us, I think it's important to look at the societal problems, you know, unemployment or violence against women, all these different things. I think bullying also is a societal problem, but I think we also need to be more clear, because for me, you know, my 20s were better than my teens and my 30s were better than my 20s. And I feel like it's only going uphill from now. Like for me, the message I would say is if you're being bullied in your teenage years, you know, things can only go up from there. You know, it takes work and it takes effort and it takes things like therapy. But yeah, that for me is like, we need to also look at what are kind of the cultural messages we are sending to people. What are we telling, you know, young boys about being strong? You know, if being strong is being stoic and silent and not talking to anyone, that increases the chance for isolation. I didn't feel like I could talk to anyone. So I think, yeah, there needs to be like a multi-level, bigger approach, I think, as you know, many of you have said.
Thanks a lot.
I do think it's important. You know, I think the data here are showing, Thomas, just to say, I think it keeps getting better, that we're the happiest in our 60s and then in our 70s. So there's something in life, and maybe it's perspective and experience or lowering our expectations. I'm not sure. But I do think it's important that we're looking at the individual level and the community and societal level, because, you know, from a public health perspective, if we can impact more people with our policies, we have a better shot at lowering the number of tragic deaths by suicide, just because our very specialized treatments and interventions, right, due to both stigma and access, we won't reach large numbers worldwide. We can reach much larger numbers if we can figure out how to address problems like child maltreatment and domestic interpersonal violence, the problem of young people having access to drugs and alcohol. These are not easy problems, and it requires that when we think of policy, we get out of the narrow silo of thinking about policy for suicide prevention specifically. Because when we're talking about reducing child maltreatment and interpersonal violence, those are risk factors for a lot of bad outcomes in addition to suicide. And it's like we need to link arms with people who are working in other areas in prevention when we think at these broader levels.
Thanks very much, Dr. Cheryl. Completely agree with all of that. And linking arms is really what C20 is about. It's about us really starting to come together and work together to help bring about a change. Let me move on to another question. And I want to ask particularly Dr. Cheryl and Dr. Soumitra, however, others of course can jump in, but you've both been doing some really interesting and very wonderful, effective work and research and creating programs that can prevent or reduce suicide behaviors and even self-inflicted deaths. Would you please share a little bit about that? I know, Dr. Cheryl, you have a few slides you can share, but both of you, we would love to hear about the work you're doing.
Dr. Cheryl, you go first.
Okay, I'm going to go ahead and share my screen here. Just give me a moment.
Sure.
All right. I think you're seeing probably more than you need to, but let me try to change the view. I'm sharing this slide only because I think it's for people who are interested. It's a really nice reference of the state of the world's children that came out in 2021 from UNICEF. I think Dr. Malini shared some figures from this, but it has a lot of information about mental health in many different countries worldwide. One of the things it even highlights is that over 80% of young people think it's best and really important to share their struggles with others and get their support. But this is chock full of really useful information. This Dr. Malini mentioned as well, is coming from the UNICEF report, just showing that suicide is one of the leading causes of death. Notice that interpersonal violence, which we know is a risk factor for suicide, these are two that we might even think in terms of policy of trying to address them together. We've started to talk about this, and in addition to some of the societal and cultural ones, trauma is related. These risk factors are happening on all levels. This is an individual, family, community issue, but it's also a societal issue. And persistent stress certainly is as well. These are very well-known risk factors for suicide in young people. The reasons for them can be at the individual, family, community, and societal levels. I put in bold on the one side there, low social connectedness, rejection, and isolation. Because the intervention that I want to share just a bit about is really focused on that. And I think when we started here, Gabriella highlighted the importance of that. The connectedness, a sense of belonging. And there can be lots of risk factors, lots of reasons on all levels, but at the end of the day, a real sense that I'm contributing, I'm not a burden, I'm belonging, I'm connected, I feel there's someone I could turn to at school seems to be extremely important to youth suicide risk. We've got lots of data. I don't think we need to go into the detail. This was a huge study. This one was in the US, showing that school connectedness, again, it's not just protective against suicide outcomes, but all kinds of outcomes we're trying to prevent in young people. The same with family connectedness. It's protective against prescription drug misuse, against sexually transmitted disease, against physical violence. So we don't doubt that connectedness is something that we should address. The intervention we developed is called the Youth Nominated Support Team. We developed this originally for teens who had acute suicide risk. They were hospitalized because the risk was so high. And we wanted to develop something that would be a bridge for the youth and their families when they left the hospital, went back to their family, community, and school. And the goal of this intervention is to have a well-informed adult support network. So it's about building a group of adults around a teen that understand how they can be most helpful with the teen. The support persons are nominated by the youth, so we're empowering young people to nominate adults that they know in their worlds to participate in this program. They are nominating, in addition to a parent, aunts, uncles, grandparents, older cousins, adult siblings, some teachers. We have youth group leaders, spiritual leaders, maybe a coach from a sport team they're on, fictive kin, people who are like family to them. And these caring adults, we bring them in, and with the youth and parents' permission, they learn what the youth is struggling with. They learn how to be supportive, and we support the adults on a weekly basis. And we ask these adults to just have what they consider to be meaningful contact with the youth at least weekly, to listen to the youth, provide emotional support, encourage follow through with any other services that have been recommended. If they have a chance to kind of lean in on the side of helping the youth make good behavior choices. And then they're like gatekeepers who can have learned what are warning signs of increasing suicide risk. So we did a large study, a randomized clinical trial with over about 450 teens with acute suicide risk. And we compared just giving these youth the usual care or the usual care plus the youth's nominated support team. All the youth had an average of 3 adults in their world who participated. We helped them nominate the adults. They're from extended family. They think about their school. They think about their community. They think about their spiritual domain as well. So you can see we had many different people participating. At 1 year, at 12 months, modest positive effects. They did reduce suicidal thoughts more quickly. And the support people did encourage them to get other care, which they did get. But at long term, we looked 11 to 14 years later, and what we had was a significant impact on how many of the young people had died. And it was actually 6 times as many in the group that did not have YST. But when you look at what might happen by chance in a mortality outcome study, and you look at the confidence interval, what this means, these numbers, is that for youth who had YST, they had at least a 50% reduction by having these well-informed adults looking out for them, learning how to support them, understanding what they're struggling with, a 50% reduction in how many died in the next 12 years or so. And how might we understand that? I think it's because it's bringing these adults in the extended family and community closer to know what's going on with them. And they got very tailored information about how to talk to the youth, how to support the youth. They would ask for resources. I understand they're being bullied. What do I say? Why are they taking this medication? What can I say to them about it? Whatever their questions were, we would give them resources and talk them through it. And because this isn't a traditional treatment with a mental health professional, these are adults who are in the young person's life, and most of them stay in their life as they enter adulthood. This might be their aunt, their grandfather, and now they've been brought closer and they understand how to be helpful to the teen. So I think it just, emphasizing where we started today with support, connectedness really matter, but we can't expect all of this to come from parents. And I think this is really important when I work with young people at risk for suicide and their families. I have raised teens, have many grandchildren at this time, but I think we all recall that when our children are teens, that's not necessarily when they talk the most with their parents. They're separating from parents. They have different kinds of relationships with different adults, and bringing more adults in to know what's going on and know how to be helpful to them, there's a better chance that these different adults are connecting. The youth are sharing different things with them and going to them for different things. So it's really like putting our arms around or building a community of adult support around the teens. So let me stop there.
Thanks a lot. That was really wonderful to hear and actually inspiring and uplifting. I think it gives people a sense of hope. I certainly hope so. I also like this idea, you know, the thing about bringing elders into the lives of the young people. You know, we haven't spoken about it, but the elderly population in many places in the world is also at higher risk for suicide. And maybe some of them are those that might be helping the youth. And so maybe it's a mutual kind of a help and prevention.
Yeah, I think it can go two ways. And I think of this as one type of intervention that's non-traditional and involves support. We do have evidence of some other interventions that are helpful. Some of these are very clinical and intensive. And so they can be helpful, but they're not reaching large numbers. So we have treatments like dialectical behavior therapy, cognitive behavioral therapy that are helping young people with managing strong emotions, coping skills, mindfulness. And we have safety planning for youth at risk, where we work with the youth and their family to have a plan. The next time you're this upset, what could you do? One of the interventions that we know to be effective is lethal means restriction. And this is where you limit access to the means of dying by suicide. Here in the United States, a big focus is on firearm safe storage. In other places, the focus might be on removing access to poisons or something related to, you know, across the world, we have different methods, but restricting access seems to be an important strategy. And then just to close on one other one that we have growing evidence for, it's really, and it can be school-based or community-based, it's education and awareness campaigns. And sometimes we think of it as gatekeeper training. How can we help the various adults who have regular contact with young people to recognize risk, to know what to say if they do see risk, to respond in a way that's helpful? And these gatekeeper education and awareness programs seem to make a difference as well in the suicide rate. You have to keep doing it every year, but as a policy, it's something we might think about in communities and schools. And I'll stop there. Thank you.
Absolutely wonderful, especially this implementation into the schools is really great. And you mentioned something about mindfulness, and later on towards the end of the program, we're going to share a challenge that part of the health domain in C20 is doing. It's called 999, but we'll let that come later. It's a way to bring, to uplift us mentally and psychologically. And some of what you said, I think, Sumitra, you can relate to. Would you share some of the interventions that you all have been doing here in India? And maybe you've been carrying them to other countries as well, I'm not sure.
Thanks, Malini. All of our research that my team that does the research, all of our research group work is largely focused around India and a little bit of work in Bangladesh recently. Our research is focused on trying to solve a couple of challenges. Okay, the one big challenge that you're trying to solve is that while we know many effective interventions, you know, and Dr. King mentioned some of those effective interventions, the real challenge is taking those interventions to scale. To take those interventions to scale, meaning like imagine if you had a prototype of a vehicle and actually being able to produce that vehicle in mass numbers so that everyone can use it. And that's a different challenge to actually designing a prototype. So you know, the former would be called as efficacy research, which means you're trying to find something that works. And the latter challenge, which we try to address, is trying to bridge this no-do gap to take it to scale, which is largely implementation research. So almost all of our projects really focus on implementation research. And as a result, we collaborate with governments to try and take things to scale. And so our experiments or research is about how can we scale this up given the resource constraints that we have in places like India, you can't work without those resource constraints. We don't live in an ideal society where governments have unlimited amount of resources. And so you really want to be able to say, okay, well, how can those existing resources that we have, can those be utilized in such a way that you can do suicide prevention? So that's one way, one thing that we keep in our work. The second point is that you can think about about suicide prevention strategies and research along three broad headings, in a sense. One is what is called as universal prevention strategies, and Dr. Cheryl mentioned a couple of those. This is stuff that you do across the board for everybody in a population. So firearm restriction, restricting access to pesticides, giving young children or adolescents specific suicide prevention life skills education modules, which equips them better to deal with mood and other issues as they grow up. Now, those are things that we are trying out in our research. So universal strategies. The other big universal strategy, which actually is another low-hanging, almost zero-cost fruit for us to pick, is media reporting of suicides. We know from evidence now that how the media reports suicide can make a difference to around 1 to 2% of lives saved. Okay, now you might say, oh, that's a small number. But when you're looking at about 800,000 to 1 million suicides a year across the world, we are talking about 15 to 20,000 lives that we can save without requiring any amount of investment. It requires some investment in training journalists, for example, but doesn't require us to put money into some treatment. It requires our media professionals to change their style of reporting. Now, that's another project that we are running at the moment, which is monitoring and giving feedback to Indian media on suicide stories. So we track every single suicide story that comes up in the Indian media, and we rate it on what are called as, the WHO has kind of criteria for rating good suicide stories, bad suicide stories. And we publish a quarterly report of every newspaper and how well they are doing on a scale of 0 to 10 in terms of doing it well, not doing it well, like a league table every quarter, with the intention that it'll actually bring about changes in behavior in the media. We also follow that up with a very specific online training program for journalists in how to report suicides in the media. So you kind of monitor what they're doing, but you also provide them with training to improve their reporting. So these are like universal things that we do. We have projects currently which are looking at, for example, gatekeeper training. Gatekeeper training of school teachers. School teachers are a huge resource in countries like India and many low and middle income countries. How can we train gatekeepers to school teachers to actually be able to identify young children who might be at risk, and what referrals should they make? And so we are trying out different strategies for training them, online, offline, various ways, and seeing which one works better given our resource constraints in places like India. So those are universal ones. Then you have what are called as selective or selective strategies, which you aim at high risk groups. Somebody who's at a higher risk of dying by suicide, and so we're looking at some of those high risk groups where we are trying to do intervention strategies. One of them, for example, is we have a very specific youth suicide prevention program which uses peer-led counselors to provide like a chat text line support to other young people from their same background who might be at risk of suicide, and that we are testing that out, how well that works and how well it is received by young people. And finally, you have what are called as indicated strategies. Indicated strategies are where somebody is at a high risk for suicide or has attempted suicide. So we have a project in Chhattisgarh, a state in central India, to work with the government to see how the public health system could provide safety planning and contact to people who have attempted suicide and come for medical help to the hospital. So what happens normally is they get discharged from the hospital, nothing happens after that. And we are trying to put in place a system whereby the community health workers could provide the follow-up and could also make a safety plan for them so that the next time people feel suicidal, they know what to do rather than to attempt another episode of suicide. So there's a range of things that we work on across these various domains of universal, selective, and indicated strategies. And as I said, the main thing is to work with governments to see how can these interventions be integrated into existing services using the kind of resources that we already have, rather than to try and think of very expensive human resources or expensive interventions, which countries like India really cannot afford to do. And there are lots of really low cost, bottom of the pyramid interventions that we should be doing and can be doing, which are not very hard, not going to cost an arm and a leg, so as to speak, and allow us to scale up to a large population of 1.3 billion people. Thank you.
Thanks a lot. Really, again, more wonderful ideas. And I really appreciate looking at low-cost ways to help prevent suicides. And Swamiji, did you want to add to this?
Oh, no, thank you.
What can we do for someone who is thinking about harming themselves or who's going through a particularly hard time, whether it's a youth or an adult? And of course, everyone is welcome on the panel to respond. But Thomas, maybe you would want to share from your experience a little bit. You've shared some of your experience, but how would you help people who are struggling with having a lot of suicidal thoughts?
I think for me, I think the first part is what I mentioned also before, is I think, at least from my personal experience, and again, your mileage may vary, from my personal experience, I think a lot of my problem was I'm in this situation, I will never get out of this situation. And I can't, continue living forever in this situation. And I think this can be true whether you're a teenager or you're, older. I think this, like, helping people understand that things can actually get better and that the current situation doesn't need to be the situation for the rest of their life. And I think the other big part is, and I think this has been mentioned by other people also, it's about like reaching out, I think, and getting help, getting support, being able to talk to people. I think for me, I didn't see any real progress, any real improvement in my situation until I started actually opening up and talking to people in my community. And
Thomas,
from there, yes, sorry.
Just I want you to share with people a little bit about actually what precipitated this. Because as I recall, you had shared with me, you had some good friends in your school. And then when you all moved to the next grade or the next system in your school, could you share a little bit so people know exactly what happened to
Sure.
you?
Yes, sorry. So for me, after primary school, I went from primary school to high school, a high school that was pretty much linked to the primary school I was in. And most everyone from my primary school went to that same high school. And once I got into high school, I think fairly quickly, bullying started. For me, this was mostly, in my case, this was mostly mental. There was not really that much physical bullying, but it was a lot of mental and emotional bullying, a lot of, a lot of things making me feel like I was worthless. There was a lot of, I think it's degrading, like a lot of degrading experiences, a lot of making me feel like I was trash, like I had no value, like I, couldn't really do anything good. And that kind of combined with very heavy isolation. In my day-to-day life, I didn't really have anyone around me I could talk to. I think partially, and I think I alluded to this before, partially from like a societal concept. I didn't feel like I should really talk to someone. I struggled a lot with, feeling that everything was happening was my fault. I think this is one of the biggest kind of cruel twists, is I was being bullied and yet I was kind of blaming myself. And in part, I think because I was blaming myself, I wasn't trying to reach out to anyone. I wasn't able to find the support at that time that I so dearly needed.
So
I
really,
think,
I think what I hear
Mhm.
you saying is you felt you were being persecuted, and that became so internalized in your own mind, was also adding to the self-persecution. And you didn't
Yeah.
see a way out. You didn't. Were you at this time starting to have a lot of thoughts of death?
Yeah, this very quickly turned into, very quickly, I wouldn't say very quickly, but this did turn after some time. I think this did turn into, well, I can't live like this anymore. There is no hope. And I started to think, okay, well, maybe I should just end my life. If I can, I can't live like this anymore and I don't see any way out. And so I started both thinking of what are the different ways I could take my own life. And in combination with that, I started to write my suicide note, because for me, it was very important. I wanted to find some way to absolve my family of any guilt, because my parents, for all their faults, are loving and caring parents. And so I wanted to somehow figure out a way to make it so that I could step out of life and not make them feel bad. I did at some point conclude, I tried this for a long time, and at some point concluded that I wasn't able to find a good way to explain to them what I wanted to do and why I wanted to do it. And that, in combination with some very mean comments by some of my classmates, alluding to how cool it would be if they could bully someone into committing suicide, I think created a kind of push in the very stubborn part of my personality into, well, if I can't explain to my family what I want to do in a way that won't make them feel bad, and if I can't, and combined with, I don't want to give anyone else the satisfaction, which I think, looking back as an adult, is just, a ridiculous situation, but I don't want to give them the satisfaction of seeing this. I transferred from someone who was actively looking to commit suicide to just hoping for death to come. And I changed into every time I walked by a car or walked by a train or got into any kind of situation, my mind would just go to, what if this car swerved and hit me? What if this train derailed and hit me? What if I tripped and fell and this train ran over me? I was looking for I didn't want to live. I was looking for a way to die without being the instigator. And this became almost like a constant thought. I couldn't, walk for 5 minutes without this thought. So this is kind of what it transferred into for me, just like a very strong desire to die, even if it wasn't a strong desire to commit suicide anymore.
It seems like you actually had some compassion for your family when you realized there was no way they weren't going to feel bad. And the thoughts continued. But can you tell us, just give us a summary of how you were able to move from that? And then what would you say to people who have chronic suicide thoughts? So how did you move out from that? And then how would you advise others to try to move away from suicidal thoughts and plans?
Yeah, at some there came a point in my life where I realized that I had this concept in my head at that point where I was like, I don't really want to live, but if I'm going to but I want to live. Like, I want to get back into a place where I'm actually living and not just, waking up in the morning and going bed at night and just trying to, survive through the day. For me, the big first step, and I kind of see this as this like concept. For me, the big, I think, step was to actually start talking to people around me, to actually reach out for help, because stubborn as I was and intelligent as I think I am, I wasn't there. This wasn't something that I could just solve on my own. This is something that I needed help for. This is something that I think, people, anyone who's struggling with this, getting help, I think, is the first step. Talking to family, talking to friends, even though it's very difficult and very scary, because there's so much stigma and there's so much like this. I had the idea, if I tell this to people, people will think I'm weak. What I found many years later is I don't actually think I'm weak. I think I'm strong for going through this and for pushing through this. So when I started opening up, this is also when I started to be able to get help. I was able to start going to therapy. I was able to get support in, like, how do I handle this? How do I get out of this situation? I think talking to people and getting professional help is very important. I would also say it might be important to not try once and if that doesn't work out, not try again. The first therapist I worked with, while I think she helped me some, I don't think she helped me that much. So I saw the second therapist, and that second therapist helped me more. And it's, the first person I talked to was not necessarily as helpful, but the second person I talked to was more helpful. So I think it's important. It's important to reach out and to find help where you can.
Wonderful. Thank you very much for sharing that. And honestly, I would really like to hear what others have to say. But first, I want to present this last question because it's a little bit controversial. It's very different, and I believe Swamiji will be able to respond to this, as will others. And Thomas, you may want to add to it as well. So the question has to do with what I think many people have asked, and the question is, what happens to a person when they take their own life? And it seems like there might be two diametrically opposed paradigms. And one of the paradigms is when a person commits suicide, the question is, are they gone forever? And one view is they're gone forever. We are this body. When you dispose of the body, that means you are no more and your suffering is no more. There's no continuation. But there's another paradigm that says we are not the body. We have the body almost on loan. We're not the creator of the body. We're not the owner. And we don't really have a right to injure or kill it. And when the body is destroyed, it's not that your sorrows are gone. And this paradigm, the belief is that we are not the body, that we're actually a soul residing in the body. And just like if you rent an apartment, you would not be free to destroy it. The body is something of a sacred vehicle through which we go through life for the purpose, as I understand it, but Swami can explain more, for the purpose of overcoming our shortcomings, our negative tendencies, so that we might rise to a higher level, more fulfilling and happy level of life. So I would like to ask for some comments on this, these opposing paradigms, what happens to the body. And Swamiji, if you would take the lead on this and start with the answer for this, I'd really appreciate it.
Yeah, thank you, Malini. First of all, before we start going over there, I just wanted to say a couple of comments. One is, my spiritual master, Amma, always says this, that the human life is very precious. We spend millions of dollars for saving a life. But at the time that we take our life, we do not think about this. So whether there is a afterlife or whether this is going to end just like that is not the question. Here and now, the first question is, isn't our life very precious? And people have to consider that. And as most of you are saying, we can look at the tiny bit of darkness that's surrounding us right now, but there is always light at the end of the tunnel. So what we need to do is not focus on the darkness right now, but to look at the light and always be optimistic that there will be a solution and there will be a better life that's always for us. And secondly, to answer your question about what happens, I have to just, of course, I have not personally had that experience of dying, so I cannot say authentically or experientially, but from what Amma has taught me and from what the scriptures, the Vedic scriptures have said, our human psyche or human life has 4 parts to it. The first part is the physical body that we see. Then the second one is the mental, which is called the subtle body, which are our thoughts and our all the actions that we have done has been recorded. And the third one is known as the causal body, which is the called the ignorance, that we are not the supreme consciousness, but we are just the this limited body. And the last one, as we say, is the supreme consciousness or the soul. And what happens when a person takes or dies or takes their life is the same process that happens, that it's only the physical body that goes away. Whereas the subtle body and the causal body remains. And of course, the soul is always ever present and omnipotent. So what many people who tend to take their lives want to put an end to their suffering, thinking that like this is going to end as soon as I take my life. No, it's not going to end there. As Amma points out, Amma says that when we take our life, suppose we're supposed to just take like 10 kilograms of weight or 10 pounds of weight in this lifetime. We'll have to take another 100 pounds or 100 kilograms of suffering in the next one. So this is not an end to it. So this is one of the things that we have to understand, and we have to make other people understand that there is, just because we take our lives, it's not going to end the suffering. And the next one, what we have to also understand is that many people who have just taken their life and have come back not being successful and have gone through near-death experience, and comparing with the near-death experience of people who have have gone through the process of death, they say that the people who are taking their life go through a lot more suffering during that time. And this has been recorded, and this has been the experience of many people. So one of the things that we have to understand is this taking away the life is not a good experience. In the social media, as Dr. King was saying earlier, it's becoming more popular saying that, suicide is cool. No, it's not. It is really a much larger suffering that what one can perceive or understand. And this is not an end. So the question is, what can we do and how should we do? First of all, bring awareness to the different, give this kind of awareness to children at a very young age itself. And in one of the other things which Dr. King was referring to is that now we have become isolated. For the children earlier, they had the support system from their other family members, not only from their parents, but their relatives, from their especially from their grandparents also, which is not available now. The grandparents had so much of experience to share with their younger generation. So that is other thing. And the most important thing, I'm just, I'm not going too much, but to summarize, each one of us have the responsibility to look out for people who have such kind of a tendency. I recently heard about a Japanese person who would go and stand near a very popular place where people used to commit suicide. And every day he would go and stand there. And when people would come, he would look out for them and counsel them and slowly speak to them and ask them not to take their lives. And he has saved hundreds of lives. And there are popular spots like this spot in Japan, or like the Golden Gate Bridge that I've seen many people are taking their lives, or Niagara Falls. So there are so many places where this happens quite often. And it's equally, as I said, it's equally important that each one of us listens, because some of the comments from the the people who are participants have said that there's no proper listening. So it is very important that we listen to others. And I've heard complaints from children from their saying that their parents, when they talk to their parents, they are just sitting on the computer and saying, So this is the most important thing, is that we listen. Because we have to put down our, smartphones. We have to just completely give our time to these people and listen to them properly and empathize with them. And not only that, understand their position, and then only we will be able to help them out. And the last thing that we can do is prayers. We can pray for the people, and we can also pray for the people who have passed away. And Amma says that when they commit suicide, it's very difficult to come back into the human realm and take a body as a human being after committing suicide, because it takes more time, because they have to exhaust a lot of karma. And so it takes more time for them to come back as to another human body. So we, as all of us, we have that, as I said, a social responsibility to listen, to care for, and to teach other people about what happens after taking their life. So with this, I would, convey that to all the people who are listening to this. Yes.
Thank you such words of wisdom. Such a broad area you've covered, the lost art of listening, and what we can do as lights in the world, going places where suicides tend to happen, and we can organize in groups and be there to, try to talk with people even. It's wonderful, wonderful. Dear panel, I'm just aware that people want to ask a couple of questions of you, and we're really running out of time. So I would like to hold what Swamiji said and ask if we have one or two questions that we could let the panel respond to. Shiva Priya, do we have one or two questions that you can share with us?
Yes, ma'am, we have.
What question? Can you start with one?
Yes, ma'am. The first question is asked by Komal. The question is, what is spiritual counseling and what's its relation with conduct disorder?
What is spiritual counseling and what is?
Relation with conduct disorder.
Okay. Were you all able to understand that? So invite the panel to respond. What is spiritual counseling?
I can answer about spiritual counseling as I was talking about that. You know, one of the things is understanding where they are coming from, empathizing with them, and also giving them pointers. One of the things is, you know, the repeated thoughts that come into their minds is about how, you know, I just want to end my life. So just giving them some kind of a tool where they can stop this continued thoughts about taking their life. So something like meditation or doing some mantra japa, or you know, doing something which is will help them to stop this mind, which is just making so much of noise. We can't hear you. You are muted.
Thank you, Swami. Any other comments in response to this question? Otherwise, we'll move to another question from the audience.
I might just want to add something, Swamiji.
Sure,
Thank you so much for what you said earlier. It's, first of all, extremely important what you were addressing about the soul's journey, because the body is one thing, but it's the body-mind. And if the mind is causing the suffering, then it's not by eliminating the body that the suffering is isolated. That's it. It just, unfortunately, it's that. And there are many studies now today that actually equate this spiritual practice into reality. There is a quantum body. The mind body is a process. So I just wanted to underline that from also a meta-analysis perspective, because it's very important. But I also wanted to underline something that's beautiful in relationship to what Swamiji was just saying. There's this professor called Dr. Lisa Miller at Columbia University, and she does a lot of work with children and education around children. And one of she just did a study, and I'm going to read it to you because it might be very interesting for everyone. Dr. Lisa Miller, PhD, found that a child with 5 times less likely to be depressed when spiritual life was shared with a mother. So that's very important, that connection with the mother as spiritual education for the future of her lives. Her research shows that spirituality not only was a hugely protective factor, but it was the biggest protective factor over the course of an entire lifetime. So I think that that's a wonderful thing, because these are tools like one of the professors said before, are integrated already. We can do this. It doesn't not cost any money. This is something about the affection, the appreciation, the deeper listening into our family connection. And like Dr. Cheryl said, yes, the social media has deconnected, quote unquote, our family table around, you know, how we operate with each other. But if we were to just infuse our words with consciousness, so that one word is potent and expands almost like a sutra when one addresses one another in life, then the love in action can occur. And these are tangible tools, like Swamiji said, that are in our hands. And like our dear Amma, our teacher, who is the Divine Mother, quote unquote, within this context, and the chair of C20, it's how do we create that love in action? And I think it's tangible. These are tangible tools. This is not far out. And we start with that. So that's what I wanted to comment on. Thank you, Swamiji. Thank you.
Thank you. And it's a continuation of Swamiji basically saying we are more than a body. We are a soul, and we are a soul that's in transition and trying to evolve. And what I really appreciate that, and especially what you were saying about really our suffering is coming in the mind because of the way we're interpreting the world or experiencing the world around us. But if we are a soul, then we can think that, first of all, we should understand that life will have wonderful times and challenging times. It's just a part of life. but we learn to manage them, especially with support. We have to understand that some are more vulnerable than others. There's so many ways we can try to support each other. We can have, I think we need to let Dr. Sartak now speak and give us a summary of everything. Dr. Sartak has been patiently listening to the panel.
Well, thank you so much. And
Dr. Sartak, just
yeah.
one thing, because
Yeah.
I just want to say, Dr. Anaswarta, please put in the chat your question or your comment. I don't know if, because she is raising her hand there, and I don't know if we're able to, if Abhijit is able to unmute her, and we could just let her say a couple of words, and then we can go on to your summary.
Yes, I think she's on mute now.
Okay, Madam, would you just share your comments, and then we'll let Dr. Sartak continue.
Yeah, I would. I'm Dr. Anashwara Dev. Can you hear me? Am I audible?
Yes, you're very audible. Thank you.
Okay, thank you. So I'm Dr. Anashwara Dev from Kochi. So I would like to make two suggestions. Actually, though stress has been found out as a causative factor for many of the mental health disorder as well as the other chronic disorders, it is not recognized as a causative factor by WHO. Even we can see cancer causes, even in that not mentioned. So why is it so? I was surprised. And so if in policy making, if we are making a suggestion to add causative factor as a stress factor as a causative factor, it will be helpful. And I would like to tell that how it's helpful, because if we are recognizing stress as a causative factor, while treating the other chronic disorders, so they will look at it, the stress factor, and the patient, they can suggest psychological support or even a psychiatric support so that the suicide can be prevented. So there is a gap there. So because mind and body is not a two entity, it's a single entity. So whenever there is a chronic disease, I think there will be a change in mind as well. Everyone has a story to tell. So there will be a change in mind. So mental support in every chronic disease is a must, I guess. So that's the thing I want to suggest. Kindly look into it. Kindly consider that.
Thank you, ma'am, for your comments.
Thank you for the opportunity.
I really want to apologize to everyone that this has been such a rich experience, and so many things, wonderful things people are sharing. I wish we had time to go on and on, but again, I'm aware of the time. I would like you to stay a few minutes longer. Let's, Dr. Sartak, please share his summary. We'll give you a very brief video. It's 1 minute. It's very inspiring, and also a vote of thanks. Dr. Sartak, over to you, sir.
Okay, thank you so much. And I'm so honored and humbled to be doing this, and I will try to do my best because it's been an incredibly humbling 2 hours. And the first thing I wanted to say before I summarize is I just want to thank Gabriella and Thomas for their bravery, Swamiji for your sage guidance, and Dr. King and Dr. Shamitra for your incredibly lucid science that backs up so much of what was said. So I'll do my best to keep this brief. I think the first thing that I noted here was the, apart from the fact that we're talking about 837 souls in a year that are lost to suicide, what was striking was to also think about the fact that each of those beings is connected to at least 15 to 20 other people. And so I did some quick math, and that means in the last 2 hours that we've been sitting together, wherever we are, that's 4,500 people who have been affected in some way, either directly by their own loss of life or because someone close to them lost their life. And that is a mind-blowing idea. And with regards to those numbers, just also wanted to know what was shared with us, that 34% of those people who are at risk are under 18, and it is the fourth leading cause of people between the ages of 15 to 29. So the numbers are truly staggering. And then as we thought about that data, we moved to some of the reasons why this happens. And it was shared by many of the panelists from either their personal experience in working with others or direct experience, that It is isolation, loneliness, inner turmoil, trauma, gender-based violence. There is an incredible role that is being played. And while the data has yet to prove causation, there is an incredible correlation with the onslaught of technology, making this universal problem even worse in terms of what is happening in this. And I would call it, as someone who works on epidemics and pandemics, this is clearly a pandemic. And it was also shared by Dr. King that it's something that could be building over time, over a cumulative set of experiences and chronic stress, but it can also be a more recent problem, something that happens over the course of days, weeks, and months. And I think that's also something profound that I took away, just because it means that we have to be ever vigilant. I was also, Dr. Shamitra shared that we really do, and he emphasized these points around the structural parameters, some really incredible data around post-COVID and different forms of social upheaval. But I think on a brighter note, what was shared was also some striking data around the kind of remedies that can happen at a policy level. For example, cash transfers. I believe he cited statistics from Brazil, where cash transfers had the result of a 61% reduction in suicide, with similar results in Indonesia. And at the same time, some profound effects felt as a result of interventions related to educational stresses. So those were in relation to some of the structural forces, some of the reasons why these things happen. And then without going into too much more of a summary, I think the very last part was perhaps the most inspiring. And I don't know if I can share my screen. So if I can't, I will just let go of that idea. But I thought it would be nice. Can I share my screen? No, I can't. It doesn't matter. I think that as Gabriella pointed out, as Swamiji so importantly noted, taking away life does not remove the burden. I think that was something that was profound and to contemplate. And then as Gabriella remarked around, and Thomas remarked around this as well, as corroborated by our experts as well, but that each of us has a responsibility and we have tools. So while we think about these massive policy solutions, we also can just recognize the power of deep listening, of being human, of opening ourselves to understand who's right in front of us and make ourselves available to them. And so I am going to apologize for the many omissions that I'm sure that I've made. But thank you, Dr. Malini, for inviting me and for making the space for this. This was in itself, I can say for me anyway, it was it was something that I felt some sort of healing even occurring. So thank you.
Thank you very much, Dr. Sarth. That was a wonderful key points that you highlighted. And I would like to invite now Krishna Priya, please, to give the vote of thanks. And please don't go yet. We still have a brief little video and want to see if anyone else on the panel has a final word. So Krishna Priya.
Good evening, everyone. Myself, Krishna Priya. I am working as a coordinator for the C20 Integrated Holistic Health
Krishna
Working
Priya,
Group.
voice is a little soft. Voice is a little soft.
Okay. My name is Krishna Priya. Is it audible now? Okay. My name is Krishna Priya. I'm working as a coordinator for the C20 Integrated Holistic Health Working Group. It gives me such great pleasure to share the vote of thanks with you all. I would like to extend my heartfelt gratitude to all of you for attending our webinar today. First, we thank Mata Amritantamayi Devi, whom we affectionately refer to as Amma, the chair of C20, for giving us this opportunity to be involved in the C20. And to work with people around the world towards a collective effort to improve good mental well-being for us all. Amma is tirelessly serving the world and inspiring so many of us to do our best to do the same. We sincerely thank the wonderful leads of Integrated Holistic Health Working Group, Dr. Priya Nair and Dr. Jaydeep Menon. I would like to thank our esteemed speakers for taking the time to prepare an informative and engaging presentation. We appreciate your willingness to share your expertise and experiences with us. I would like to personally thank Dr. Cheryl King, Swami Dayamrita ji, Dr. Soumitra Pathare, Ms. Gabriela Wright, and Mr. Thomas Merchant, and last but not the least, Dr. Sarthak Das for the closing remarks. And thanks to our operations team, including Shivapriya, Abhijit, Ms. Anita, and Mr. Sasha, who worked tirelessly to ensure the smooth running of the webinar. Moreover, I would like to thank each and every one of you for your participation, active engagement, and valuable contribution during the question and answer session. Together, we can make a positive difference in this world, one person at a time, one light at a time. Let's keep our lights shining bright, never give up even in the face of challenges, and always hold on to a positive belief that life will always overcome darkness. We thank you all warmly. Good night and happy weekend. And we will end this session with a 1-minute video. Thank you.
Abhijit, do we have the video?
You are the light. 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 Om Namaste Sukhino Bhavantu.
Thank you, Abhijit. I sincerely want to thank all of you for attending this program tonight. I'm so grateful to our esteemed panel. I'm grateful to all in the audience with Dr. Sarthak, everything that was said. I'm sorry we didn't have more time for your questions, but we never really know how long these events are going to go and how much discussion will happen. We ask all of you to go forward, that we all can be a light and we can all make a change in trying to reduce suicides and support those who are struggling. Namah Shivaya to everyone.